Weight loss injections like Ozempic may do more than just slim you down. They may prevent you from getting dementia. But is there any real science behind that claim? Hi, I'm Luke. I'm a PhD student and a health economist at the University of Oxford. In this video, we're going to talk about GLP-1 receptor agonists, the drug class behind Ozempic, and what we know so far about their potential impacts on dementia risk. We'll look at the latest studies, why diabetes is so closely related to dementia, and what the current clinical trials are trying to uncover. There have been lots of discussions in recent years about the impact that glucose-lowering medications like GLP-1 receptor agonists have on the incidence of dementia. Diabetes is a key risk factor of dementia, particularly vascular dementia, due to the damage it can cause to blood vessels and arteries in the brain. It's also a risk factor for Alzheimer's disease due to the buildup of amyloid and tau proteins linked with insulin resistance. Diabetes can also cause the immune system to become overactive, which can increase inflammation in the brain and be another potential link between diabetes and dementia. There is growing evidence that metformin, a glucose-lowering drug that's used to treat people with diabetes, may help to prevent or slow the development of dementia. However, there's currently no strong evidence that newer drug classes, SGLT2 inhibitors and GLP-1 receptor agonists, have similar benefits. Unlike metformin, these newer drug classes deliver health benefit largely independently of glucose lowering. What that means is they reduce the risk of diabetes complications, but they do so without having a large impact on blood glucose levels. A recent study published in the Journal of American Medical Association, JAMA Neurology, found that the use of GLP-1 receptor agonists was associated with a statistically significant reduction in all-cause dementia incidence. The study was a meta-analysis of 26 clinical trials, 10 of which were of GLP-1 receptor agonists, that reported dementia diagnoses and/or changes in cognitive scores in trial participants. It should be noted that the authors were also interested in other drug classes, sodium glucose cotransporter 2 inhibitors or SGLT2 inhibitors, and pioglitazone. SGLT2 inhibitors work essentially by preventing the kidneys from reabsorbing glucose into the blood. Pioglitazone works in a different way by improving the sensitivity of your tissues to insulin, essentially allowing your body to use insulin better, which helps to reduce blood glucose levels. Okay, here are the findings from the study. Please excuse these graphs. I know they're not the most inviting things to look at, but let me talk you through it. These are called forest plots because apparently they look like a forest. The middle line, or the trunk of the tree, represents, in this case, no difference in the incidence of all-cause dementia. In other words, it doesn't affect dementia incidence. The horizontal line, or the branches, represents each study, where larger branches show that there's more uncertainty around the results, and shorter branches show that there's less uncertainty around the results. The authors use a statistical method to weight studies based on how reliable the data is, whilst also accounting for differences between studies so that we get a better sense of the average effect across studies. The square points on each of the branches are the average effects for each of the studies, where those located to the right of the midline are associated with an increase in dementia incidence, and those located to the left of the midline, or the tree trunk, are associated with a decrease in dementia incidence. The big diamond is the average effect across that drug class. Okay, well, what do these plots actually mean? Well, SGLT2 inhibitors and pioglitazones were not associated with an effect on dementia incidence or cognitive impairment. The diamond for the SGLT2 inhibitor looks like SGLT2 inhibitors increase the risk of dementia, but this would be a mistake to interpret the figure like this, because the average effect of the SGLT2 inhibitor crosses the vertical line, so it's not statistically significant, and we can't say it increases the risk of dementia incidence or cognitive impairment. However, very interestingly, the GLP-1 average effect was to the left of the midline, which suggests that GLP-1s are associated with a reduction in dementia incidence and/or cognitive impairment. Just in the interest of reporting the full results, the very bottom diamond is the average effect across each of the subgroups. What it shows is that there wasn't an overall effect across these drugs on dementia incidence or cognitive impairment. The authors also did not report an effect on Alzheimer's dementia or vascular dementia specifically. What are the problems with this study? Well, firstly, the trials that have been included in the meta-analysis were not designed to detect changes in dementia incidence. They collected measures of cognition and whether a participant was diagnosed with dementia during the trial, but they were not powered to detect differences in these measures. Equally, a lot of these clinical trials are quite short, just over 2.5 years on average, which makes it difficult to know whether the effects that we see will persist after the trial stops collecting data. Do GLP-1 receptor agonists reduce the risk of dementia or slow down or prevent dementia development? As of April 2025, we don't know. But hopefully by early 2027, we should start to get some answers. There was a promising phase 2b clinical trial that was presented at the Alzheimer's Association International Conference in July 2024. In short, the ELAD trial assessed whether once daily 1.8 mg liraglutide, a GLP-1 receptor agonist, changed how the brain uses glucose in regions of the brain that are affected by Alzheimer's disease. Sadly, the trial did not demonstrate its primary objective. However, the trial did show statistically significant benefits. A 50% less brain volume loss in critical areas, and 18% slower cognitive decline in those taking liraglutide. Because the primary endpoint or the primary goal of the trial was not achieved, these secondary endpoints are simply just exploratory, and they certainly cannot be described as causal. However, they do provide an indication that GLP-1s may have a neuroprotective effect. It's thought that the mechanism of action is through reducing brain inflammation, improving the signaling of insulin in the brain, and mitigating the effects of amyloid beta and tau proteins. There are 2 large-scale randomized controlled trials currently underway, the EVOKE and the EVOKE Plus trials. They are seeking to answer the question of whether oral semaglutide, a GLP-1 receptor agonist, improves cognitive and functional impairments in people with early Alzheimer's disease. They are also collecting potentially important biomarkers and neural inflammation markers, which will help improve our understanding of how GLP-1s potentially reduce or delay cognitive decline. The data for the trial should be available by October 2026, and given a few months to analyse the data, we can expect the results roughly by early 2027. So while we can't currently claim that GLP-1 receptor agonists prevent or slow dementia, hopefully we're not too far away from having an answer. If you found this video useful, please leave a like and let me know what you think about GLP-1 receptor agonists being used to treat dementia. Cheers.